So looking out at all of you, it looks like a lot of you have probably heard this talk in talking about things that have happened to you, treatments you've had in the past. You've probably heard me say these things about 100 times. So it's important that we go over them, but I also want at the end of my talk for you guys to ask questions because you know me and it's all about you. So the couple things that I decided to talk about, because immunotherapy is very broad, and Amanda touched on, gosh, there were 3 slides worth of treatments that we have that are considered immunotherapy. So I chose to talk about the PD-1 inhibitors and the CTLA-4 antagonist ipilimumab. So we have, Keytruda, Opdivo, Yervoy, or as we like to call them, pembrolizumab, nivolumab, and ipilimumab. We like to confuse you by using as many names as possible. Okay, so what do these do? How do they work? This is literally as basic as it possibly can be. So the CTLA-4 antagonists, they take the brakes off of your immune system. So you're gonna make tons and tons and tons of T cells. T cells are the things that help fight the things that don't belong. PD-1 inhibitors, alternatively, sort of unmask the cancer cells. So they allow your immune system to see things that they shouldn't be there anymore, and mark them for programmed cell death, which PD-1, programmed death. When you activate the immune system in this way, unfortunately, it can become overzealous and start to attack things that are not only cancer cells, but your normal cells. And that's where the adverse events or the side effects come from in this class of agents. These are called immune-related adverse events, or iRAEs. So what things get attacked? Really anything. So we originally, when all of these things were FDA approved, and when they were going through the clinical trials, there were some main ones: the gut, the skin, your lungs, and the liver. We've since found that some of the ones that were supposed to be like 1 to 2% of patients or less than that have become a little more prevalent than we thought. So it can affect your joints, it can affect your muscles, it can affect the way that you process sugar, so affect your pancreas and cause diabetes. It can affect the way that your kidneys function in a process called nephritis. It can affect your eyes. It can cause blurred vision. It can cause a foreign body sensation where you feel like something is in your eye all the time. It can cause your eyes to be very red. It can affect specific parts of your hematologic system, which is like your white blood cell count, your platelets. It can affect your nervous system, cause numbness and tingling. Certain disorders like myasthenia gravis, which probably most of you don't know what that is, but and it can also cause endocrine dysfunction. Now, we actually are seeing a lot more endocrine system dysfunction than we thought originally we were going to. It can affect your pituitary gland, which is this little tiny itty bitty pea-sized, well, I guess it's a lentil bean-sized gland that sits sort of behind your eyes. It's your master gland. It controls all of your hormone function. It can affect your adrenal glands, which sit above your kidneys. It can cause your thyroid to dysfunction. We all know what the thyroid does, so it can cause lots of things to go wrong. I'm going to talk about a couple of them. How do we determine how bad your side effect is? We use a grading scale. Grade 1 things are just a little annoying. We might notice you have a little bit of an itch, but it's not too much of a problem. Grade 2 means that it's causing a little bit of dysfunction in your daily life. And we would decide that we want to do something then. Grade 3 would mean that we think that it's a severe toxicity. It's something that would be aggressively managed. Sometimes it can cause you to go to the hospital. It can limit your ability to do normal things like get ready for work, go to work, do your laundry. Grade 4 means that we're really, really worried about it. It's life-threatening. And grade 5 means that you actually perished from one of these side effects, which is not impossible and is obviously a scary thing, and we're much better, and those things don't happen as often now. But back when I started with Dr. Kirkwood in 2005, we were just trialing ipilimumab, and we did have a lot of deaths from colitis because we didn't know how to manage it as well as we do now. Okay, on that, enterocolitis or colitis. This can actually manifest anywhere along the GI tract. A lot of times it will happen distally, so we'll see it manifest as diarrhea. People will sometimes, and we consider diarrhea to be anything 3 to 4 stools above baseline. So if you're somebody who goes to the bathroom 3 times a day, your baseline is different than somebody that goes every other day. It can almost always, we'll see abdominal pain accompany it. If you have a higher Colitis, so on the right side, pardon me, it can sometimes manifest a lot differently. So we'll have people that have cramping or nausea. It can also present very vaguely. So you might have an increase in your bowel movements and have just a fever that accompanies it. If you start to have things like the peritoneal signs, which is like when you go over bumps, your belly hurts so bad that you want to cry, or when you're walking, it hurts, or if you're not going to the bathroom at all, that's a sign that you have an ileus. Those are really, really dangerous signs, and that would be for sure hospitalization. So how do we manage it? That's on the left side of the slide. If it's grade 1 and you aren't having a lot of issues, we'll just monitor it. We'll give you things like Imodium. Imodium to colitis caused by one of these checkpoint inhibitors is like spitting in the wind. It won't do a darn thing. And that's sometimes how we know whether it's a side effect from your treatment or you ate too much Chinese food the night before. So Imodium a lot of times will not do anything for colitis. If you move on to stage or grade 2, we may start to consider initiating steroids. Now, a lot of times if we can, we want to do this as an outpatient because admitting you obviously exposes you to more bacteria and things that we don't want to have to do. So we would like to use oral steroids as much as possible, and believe it or not, we don't want you to go to the hospital, so we will do that as much as we can. If unfortunately you continue to progress, then we will consider using IV steroids, and if that doesn't work, then we use something called infliximab or Remicade, which is actually a much higher potency immunosuppressive agent, and you can give it every 2 weeks as you need it. We don't like to do that unless we absolutely have to. And you'll see I talk about a different agent that we just started using, which is an IL-6 inhibitor called tocilizumab that we'll talk about later. The next one, hepatitis. So this is inflammation of your liver. A lot of time this manifests sort of vaguely, not wanting to eat, sort of feeling queasy. If it progresses, patients will become jaundiced. You may have really dark urine and abnormal liver functions. A lot of times we'll know that you have this side effect before you do because we're monitoring your labs throughout the whole treatment. If it gets to be grade 3 and 4, then we would initiate steroids. It's funny, steroids are the cure for a lot of these side effects. We use a little bit different agents if you don't respond to steroids in this. We use things like Cellcept or Imuran. What happens if you get a rash? Obviously, most people know what a rash is. It's itchy. You might actually have itching without an actual lesion on your skin. Some patients will get blistering. That's sort of the Steven Johnson's like syndrome. If you get blistering, we're very worried and you will go to the hospital, just so that you know. And the blistering can turn into this toxic epidermal necrosis, which is actually pretty rare, but we actually have seen that. I have some pictures of what the rash can look like. These are pretty severe forms of the rash. But they can start out very minimal, like a fine pinpoint rash. You might not even have a rash, you just might be itchy all over. We sort of figure out the grading system based upon the rule of 9s, which is also used in burns. As you can see, as you get worse in grade, obviously your body, more of your body is involved. We try to use things like antihistamines at first, Zyrtec, Claritin, topical steroids. If those don't work, steroids. Pneumonitis. So this is something that we're actually seeing more and more, especially in the combination of pembro and nivolumab and with ipilimumab. Pneumonitis is inflammation of the lungs. It often manifests as a dry cough that doesn't produce any kind of mucus. Some patients will have shortness of breath with just minimal exertion. Like we'll talk about like, oh, I got up to get a drink of water during television last night and I got short of breath crossing the room. Lack of stamina. Oxygen saturations tend to not go down until pneumonitis is really bad. We'll try things like inhaled steroids. We'll give oxygen if the O2 saturation is decreased. That's a little thing that goes on your finger. Eventually, though, most people have to get steroids for this. And here's tocilizumab. This is an agent that we have just started using. Unfortunately, we've not been able to successfully get it approved for outpatient use, so we've been needing to admit patients. But it's an IV treatment. It doesn't cause as much immunosuppression as things like Remicade, so it's sort of an interim step that we've been able to use. These are pictures of what pneumonitis looks like on a chest x-ray. I don't wish I had a pointer thing, but it's this cloudiness that you have right here. And on the CT scan, it's all of this here. So that's what pneumonitis looks like. And I have a picture of it worse, so you can see what it can progress to. And the consolidation and that haziness, that's non-functioning lung. So that can't aerate. And so that's why people feel so short of breath. The next thing I want to touch on quickly is the endocrine adverse events. It can be underactive or overactive thyroid, adrenal insufficiency, which is sort of responsible for your temperature regulation, your blood pressure regulation. If you get hypophysitis, that's that little pituitary gland behind your eyes, that can affect all of the other things. You can also develop diabetes. It can cause testosterone to be lowered, and it can affect estrogen, so periods and things like that can be affected. These are really vague side effects: fatigue, headache, just kind of a feeling of not feeling well. It can cause some nausea. It can cause changes in bowel habits that are not quite colitis. It can cause low blood pressure, loss of sex drive, weight gain, cold and hot intolerances. We diagnose this by labs. I'm not going to go over this slide. It's really busy. We draw labs to monitor for these endocrine side effects every time that you come in, pretty much, except for adrenal insufficiency, but there are other clues in your labs that we do draw that tell us whether you have that. The neurologic adverse events are also a little bit difficult to diagnose. Guillain-Barré syndrome is when you have like a progressive paralysis from your toes up. We haven't seen that very often, at least in our practice. Myasthenia gravis, which is actually an autoimmune disorder that causes progressive muscle weakness that gets worse during the day. You can get numbness and tingling in your hands and feet because of neuritis or inflammation of the small nerve endings. It can cause a meningitis-like syndrome, encephalitis, myelitis. This is actually a lot of times a diagnosis of exclusion. So we draw all the millions of things that it could possibly be and look into all the other things. And then if they're all negative, then we assume that it's from your treatment. The most important thing in neurologic side effects is to identify that there's a problem and get you to the right person to treat it. One of the only immediate side effects that can happen from your treatment with these three agents is actually cytokine release syndrome, and it would happen while you're actually getting the infusion. A lot of times this will manifest as flushing, redness, shortness of breath. Those are all things that happen very commonly right away, and it can progress to nausea and vomiting, low blood pressure. It's almost like you're allergic to the treatment, but you're not. Your body is just overstimulated. The things that we first try to do is give you oxygen if you're short of breath, Tylenol and ibuprofen to bring down your fever, and IV fluids to support your blood pressure. If those things don't work, then we will give stress doses of corticosteroids to help support your blood pressure over the next couple of days. We'll give a bolus of something called Solumedrol, which is a steroid, and then give you hydrocortisone that you take for several days after. There are a couple people in this audience that had to do this. We also will give anti-nausea medicine if needed. If you don't perk up after all of these interventions, then we actually will have to admit you. Okay, that's it.